Let's begin with the first lecture, that is Aetiopathogenesis and Pathology of Acne by Dr. Shashikala.
Dr. Shashikala is working as Professor and Head, Department of Pathology, SSIms and RC. She completed her MBBS from BMC Bangalore, DCP from BMC Bangalore and MD Pathology from JJMMC. She worked as Professor of Pathology, JJM, and Professor of Pathology in Bapuji Dental College and Hospital. She has 21 years of undergraduate and 17 years of postgraduate teaching experience. She is Coordinator of Medical Education Unit, SSIms and RC. Her special interests are in dermatopathology. She has guided several postgraduates who have taken up dermatology topics like histopathology study of cutaneous amyloidosis, lichen planus, leprosy, adnexal tumors, keratotic lesions of skin, nerve biopsy in leprosy, etc. She has many publications in national journals. She has conducted dermatopathology slide seminars in various CMEs. We are honored to have you among us, ma'am. Thank you.
Thank you. Good morning to all of you. Today is a very auspicious day. All of us know it is Guru Purnima. So praying gratitude to all the teachers, all the gurus. We say Gukaro Andhakaraha Rukaro Tat Nivartakaha. So Guru is one who takes us from the darkness to the path of light. So darkness of ignorance to the light of knowledge. So remembering all my gurus, mother is the first guru for all of us, the spiritual and both who have taught us the medical knowledge. And my husband showed me in papers that Bangalore Dermatological Society is conducting Eczema Day today. Simultaneously, it's very nice to have an Acne Day here. And I begin with this slide which fascinated me a lot. What is most difficult of all? Next. Do you all agree if I say it is to see what is in front of our eyes? I think the next slide gives you explanation for this. Next. So it's like what the mind does not know. It holds good in all the situations and especially as pathologists. So we do talk about this a lot. And especially when concerned with dermatopathology, every general pathologist says it is too difficult. We keep getting a lot of biopsies and JJMC, a department where the skin department is very active. And if you see, all the slides are separated and kept in a tray. And only one or two will report on that. And now we are establishing a good department here also, getting a lot of skin biopsies here too. So why is it so difficult? Why the general pathologist doesn't like to look at skin? Because everything looks alike. That is where I say what the mind does not know. We may call all the biopsies as just chronic dermatitis and dispose the report. Next. So dermatologist and the dermatopathologist have a different language. The language is totally different. You see the glossary of terms, so many terms in our books. So plethora of descriptive terms. And diagnosis of inflammatory diseases is the toughest. Very easy is to diagnose neoplastic lesions of the skin, whether benign or malignant. Then, of course, many of the inflammatory dermatoses are reaction patterns and not histological entities. It's really difficult for us. So if I'm able to speak about dermatopathology, I attribute this knowledge I've learned from my professor, Dr. H.R. Chandrasekhar. Then another contribution I need to make is for Dr. S.B. Murugesh. We say teaching is the best method of learning. So he has given me many classes, postgraduate classes. He's allowed me to teach postgraduates this basic dermatopathology. But that is how this learning process of dermatopathology is going on. Next. So another disadvantage for us as pathologists, all the other specimens we receive in the department, we do have a gross look at the lesion, the macroscopic appearance. We say about 60% of the lesions we can make an appropriate diagnosis even by looking at the gross. But here, that is also a hindering point for us because you are the gross pathologist. The lesions are looked by you. So what we get is just a biopsy, a tiny biopsy, whether it's wedge or punch or shave, whatever. So we don't have much to describe it grossly. And of course, we do take the help of naked eye appearance of the section which is on the slide. Even before we look at the slide under the microscope, we look at the lesions on the section which is on the slide. So this is one example here. This is a very nice keratoacanthoma. I've clicked a picture of the section which was on the slide. The ulcer crater, which is very well seen, and the entire lesion is seen here. And of course, the standard and low power view here are very important rather than directly going to the high power view where only details are made out, and many a times we depend on your differential diagnosis. So for many lesions you would have offered us a lot of differential diagnosis. Diagnosis may go by exclusion. So these are all the features these are all the findings, and what you are going to give us helps in identifying or making a diagnosis on the given slide. And again, before I go into the lesion proper, I need to congratulate all the dermatologists, not just because you've given me an opportunity to be here. So we receive requests from all the departments for biopsy, histopathology report, but it is the skin department everywhere which writes in detail findings, clinical findings, which is very, very essential for us because most of the time it is the clinico-pathological correlation that is very important. This is about today's learning objective is on the aetiopathogenesis. I concentrate more on the pathogenesis because as clinicians you know etiology more than probably what I know, and little about the basics of histopathology because postgraduates are there, I feel fundamentals, and then going to a higher level. Next. So if you just look at Ackerman's, he has classified inflammatory disorders into many groups. There are about 9 groups. And one of the group is, next, folliculitis and perifolliculitis. So this is where this lesion acne vulgaris fits in as a pathological entity. Next. So under this folliculitis, there are so many classifications, varieties of folliculitis, but just look at this non-infectious folliculitis, which is again classified as superficial. Superficial is usually suppurative, and the first entity here is acne vulgaris. Then there are other entities. So this is non-infectious folliculitis, superficial. Next. So deep is usually granulomatous. Again, under deep folliculitis, acne vulgaris is at the top. So this is both the superficial as a deep lesion. Next. So all these are the other entities which are under folliculitis and perifolliculitis. As all of us know, this acne vulgaris is a multifactorial disorder of the pilosebaceous apparatus. And the incidence varies. So if you just look at various studies, about 85 to 100%, elsewhere it could be a little less also, but it is characterized by, as all of us have seen, non-inflammatory and inflammatory lesions. So non-inflammatory lesions are the comedones, and inflammatory lesions are the pustules, nodules, and this is. So we said this is a disease of the pilosebaceous unit. So let us just recall our first MBBS knowledge of what's a pilosebaceous unit. Sebaceous glands, we know they're found in great abundance in the scalp and face. Anywhere in the body, that is excluding this palm and the soles. This is a sebaceous gland that is shown. The entire thing is the pilosebaceous unit. So again, this is a diagrammatic representation of a pilosebaceous unit, which has got a hair shaft, then the hair follicle, the lobulated sweat gland which opens, sebaceous gland which opens into the follicle, and this is how it looks in the microscopic section. So sebaceous gland has many lobes. These are the lobes of sebaceous gland. This opens at the infundibulum into the follicle. This is the infundibular opening, the hair shaft and the hair follicle. So this is very well depicted here, microscopy. The lobulated sebaceous gland, the opening into the follicle, the hair shaft and the hair follicle. So this is again a higher power view of the same, but if we just look at the sebaceous glands, we can appreciate two types of cells. So peripherally you have the basement membrane, then there are basophilic undifferentiated cells, and then there are cells in the center which have got a vacuolated cytoplasm. This vacuolation is because of the sebaceous material which is lipid which is present in them. So when we process this biopsies, we use lot of fat solvents, so like alcohol, xylene, chloroform. So fat, lipid material dissolves. So that's why this appears foamy. Then we have vascular periadnexal connective tissue. So this is again a high power view, hair shaft, the hair follicle and the cells that line the hair follicle. I think here we can appreciate the pale staining outer root sheath of the hair follicle, then the Henle's layer. So this is the hair shaft. We are looking at the Huxley's layer, which has got epithelial cells with trichohyalin granules, like the keratohyalin granules we see in the epidermis. Then the clear cells here, outer glycogenited. So here the cells appear clear in the outer sheath because they do not contain, it's not lipid, they contain glycogen. Glycogen also dissolves during processing. The most widely used fixative is 10% formalin. It's aqueous formalin. So glycogen dissolves in the water content there. Then this is the Henle's layer. It is keratinized thin pink layer. You can see the basement membrane. This is the concept of a pilosebaceous unit and the structure of this unit in detail. So why did I spend 5 minutes on this basic histology is definitely we would have forgotten, and the way we have looked at these slides in first MBBS is different. So know the histology, you can appreciate the pathology. So acne vulgaris commences in the pilosebaceous units which are in the dermis, and I told you already what these units contain: the hair follicle, the sebaceous glands connected to the skin by a duct, that is a infundibulum through which the hair shaft passes. So the activity of the sebaceous gland starts after puberty. They are under androgenic control, and all of us know the functions of sebum as moisturizing and protecting against fungal and bacterial infection. So distribution of acne. So wherever the sebaceous follicles are in abundance are shown in the picture. So face, upper part of the chest and back with males and females you say are equally affected. So let us start with the pathogenesis. Why do we see these lesions very obviously on the skin in acne vulgaris? So there are important 4 pathogenic events. So 4 things we need to remember, the changes that undergo in the skin. First is follicular epidermal hyperproliferation. I think if I use this term, you're able to recall the histology and say which are the follicular epidermal cells. The follicle lining cells I have shown you. So there is hyperproliferation of these cells with hyperkeratinization. And this results in accumulation of keratin and subsequently sebaceous debris. I'll tell you why this keratin gets accumulated in the hair follicle. So this is an abnormal follicular keratinization. We call this as retention hyperkeratosis. So hyperproliferation of the cells as well as hyperkeratinization. So there is this hyperkeratinization and keratin binding. Keratin binds to the follicle or at the infundibulum. So there is increased intercellular adhesion molecules. That is the one which is favoring their adhesion. So even the follicular linoleic acid deficiency is supposed to be a factor. Then other factors are probably interleukins which contribute to abnormal keratinization. And electron microscopy of these cells have shown increased number of desmosomes in these follicular keratinization. So that indicates a hyperproliferation. So if you're just looking at a skin bit that is biopsied from a lesion of verruca, so where we can see acanthosis, the bridges, intercellular bridges are seen very prominently. So they are nothing but the desmosomes. We need not even go for electron microscopy to look at the desmosomes. The intercellular bridges are very well seen under high power in our routine slides. So second pathogenetic factor is excessive sebum production. And this is due to increase in the activity of the sebaceous glands and the epithelial tissue that lines the infundibulums. We have seen the hair shaft, we have seen the infundibulum, the opening of the hair shaft. So the lining cells, there's increased activity of those cells as well as the sebaceous glands. And this is again supposed to be due to or under the influence of androgens. So the testosterone in the sebum, at the tissue level, it is converted to dihydrotestosterone by 5-alpha reductase. And this enzyme 5-alpha reductase is present in the sebocytes as well as the hair follicle keratinocytes. Probably there it is causing excessive secretion of sebum. So this activity activity of this enzyme is measured and it is found to be greater in sebaceous glands from acne prone areas. That's why they have said probably this is one of the pathogenetic mechanisms or etiological factors. Though so much is spoken about, we say precise role of androgens in acne production is controversial. And it's been shown that the levels of androgens in females who are more prone for acne or who have acne is definitely more compared to the male population. Comparatively in females it's more. So proliferation of bacteria in the pilosebaceous unit is the third pathogenic mechanism. So what are these bacteria? They're gram-positive, anaerobic, diphtheroid, propionibacterium acnes within the follicle. If you see, they're called as commensals also, and many studies show that their levels or the number of bacteria may not be increased too, but they say the bacteria proliferate in these pilosebaceous units. And then inflammation. So inflammation, the various factors that cause inflammation, probably immunological mechanism also contributes. This is due the products of the bacteria which are there in the lesional area. So now I will tell you about the initial pathogenesis. There is follicular hyperkeratinization, abnormal keratinization of infundibular portion of sebaceous follicle, impaction of adherent horny lamellae within the follicle. All this we learnt in the previous slides. The first mechanism. So with proliferation of the cells, there is decreased desquamation of the keratinocytes. Decreased desquamation. So there is a hyperkeratotic plug. So what does it do? It blocks the infundibulum. So this is a microcomedon. Initial stage, the formation is a microcomedon, which is a precursor of a comedon. And this is not supposed to be seen clinically. So this is how a microcomedon appears. So we are looking at the pilosebaceous unit now. So the infundibulum, there is an invisible blocked follicle opening. So follicle opening is blocked here by the keratin plug. So this lesion, though microscopically is evident, it may not be seen clinically. This is a microcomedon. So next what happens as we proceed with the pathogenesis? The sebaceous glands enlarge, sebum production increases, and this is again supposed to be under the influence of androgens. We already spoke about it, dehydroepiandrosterone sulfate, and this sebum favors the proliferation of the bacteria, propiolactone bacterium. So it forms a nice rich growth medium for the bacterial growth, and this plugs provide anaerobic lipid rich environment. So the infundibulum is not open to the skin surface, an anaerobic medium is provided there. So from the microcomedon, we are moving on to the closed comedon, the white head. So accumulation of sebum converts a microcomedo into this. What we see here is a dilated and plugged hair follicle with a small infundibular orifice. Next. So remember the first picture where we saw a microcomedon. So this is a white head. This is the infundibulum, which is blocked by this keratin plug. It's not just keratin, it's got sebum also. And it is not it's not connected to the surface. It is closed. There's no opening. So this is a clinico-pathological correlation. We are looking at the white heads, the clinical picture, that we have a diagrammatic representation of how the white head, what is a pathogenesis in the skin, and we have simultaneously a skin section of the same lesion. Look at the epidermis, it is intact. You can see the pilosebaceous unit here, a dilated follicle. So this dilated follicle has got a lot of laminated keratin within. So it is not communicating to the epidermis. This is a picture of closed comedo. Next. So this is again another microscopic picture of a closed comedo. It is not communicating to the surface, but what has happened here is it's into the next process. So a lot of inflammatory cells we are able to see. That means this has ruptured within the dermis and evoked inflammation. Next. So as we proceed to the next stage, the bacteria thrive there, then inflammation results. So inflammation, is it immunological or is it due to the bacteria or due to the chemotactic factors that are liberated by these bacteria that attract neutrophils? So now within the follicle now we see neutrophils. So it could be, depending on the condition, a non-inflammatory. So first entity I said non-inflammatory, inflammatory. Non-inflammatory are closed and open comedon. Inflammatory is a pustule or a papule or a nodule. So it all depends. And let us just have a look at the open comedons. So all of us have seen. We need not be dermatologists to see all these lesions. Even the common man talks about the white head and the black heads. So open comedo is commonly known as a black head. This is when a follicular orifice now is open. It is distended but open. And what does it contain? You already know it contains keratin, lipids. Why does it appear black? So is it the melanin or it is oxidized lipids or the bacterial products which give a black color to it? Next. So source of the pigment again is debated. It is a active melanocyte in the upper follicle, uppermost follicle, or densely packed keratin, sebum, bacterial breakdown products which give a black color to it. But now look at this. If you remember the picture of closed comedo which I showed, this is definitely in contrast to that. We see an opening here and the keratin material coming out. This is a dilated follicular infundibulum. So with an attenuated wall. So the wall of the follicle is so much thinned out. All this time we were talking about the pilosebaceous unit. So where are the sebaceous glands here? They're not seen at all. They look atrophied or they're almost, they have disappeared here. So the epithelial lining is very thin and sebaceous glands are not seen. So this is the picture of a black head or an open comedo. This is a clinico-pathological correlation of an open comedo. So we see the lesions like this. So when we look at the three-dimensional or diagrammatic appearance, so we were looking at the closed comedo like this. Just have a look at this picture which is adjacent to it. So the infundibulum is open. So keratin is black in color. The material which is in the impacted is black in color. It's got a communication to the surface. This is a open comedo, the same picture which we saw in the previous slide. So just comparison, I put both of them together. So a black head and a white head. This can have lot of hair follicles, whereas just one or two hair follicles will be seen trapped within a closed comedo. So this is about the non-inflammatory acne, what we see. But when we proceed to the inflammatory lesions, so the increased activity of the sebaceous glands and occlusion of codified hypertrophic pilosebaceous follicles, that leads to retention of sebum, keratin, so which dilates and ruptures, retention of sebum into the follicles, they dilate and then rupture. So what happens once they rupture? So they rupture into the dermis or they rupture into the superficial zone. So breakdown products of sebaceous lipid, then this products, byproducts of the bacterium, then the immunological reaction against the organism, they're supposed to cause inflammation. So keratin is native to the body. So but if it is within the cells, it doesn't evoke any inflammatory reaction. So if it is on the surface, no problem. So but within the dermis or anywhere, so if keratin comes out, immediately the body recognizes it as foreign and there's a foreign body Janssen reaction. There's a granulomatous reaction, inflammatory reaction to the keratin. So similarly to sebum also here. And peroxisomes, all of us know peroxisomes are very small organelles that regulate cell proliferation, differentiation and inflammation. So peroxisomal proliferator activator receptors, they are supposed to modulate various functions of this peroxisome. They are supposed to cause acne, though the exact mechanism is not known. Even they are implicated in the pathogenesis of acne. So all these lead to formation of different clinical lesions. So inflammatory lesions, papules, pustules, cysts, and this we put it as non-inflammatory. Papules, pustules, nodules and cysts are the lesions of acne where we put them as inflammatory. Next. So the dilated follicles now with inflammation, they contain neutrophilic exudate. The closed and the open comedones did not have any neutrophils. Now I told you there are chemotactic factors and other immunological mechanism which makes this inflammatory neutrophils to appear at the site, and there's attenuation, rupture of the follicular wall. So follicular contents are released into the dermis and there's an inflammatory reaction. So this inflammation again may be due to biologically active mediators rather than direct bacterial action also. Next. So neutrophils are there even in the follicular infundibulum, and large number of neutrophils, lymphocytes, foreign body giant cells are seen not within the follicle, in the surrounding area, perifollicular area. I'll show you, if you just get these theoretical aspects, let us appreciate them in the pictures. So the perifollicular area, we do see this, that is because of the rupture. Then, when this follicle which is dilated, which has neutrophilic exudate. So if it ruptures superficially, that gives rise to a pustule. If it ruptures within the deep dermis, it evokes lot of inflammatory reaction, and then with healing, fibrosis and all, it forms a nodule. So these are the two lesions in inflammatory acne. So pustule if the follicle ruptures superficially, or a nodule when it ruptures into the deep dermis. And of course, the deeper nodule where it ruptures, it heals by fibrosis. And Gram-positive diphtheroids may be seen free or within the neutrophil. If you do a special stain, Gram stain, a simple stain, bacteria may be demonstrated there. And there are extensive cellular infiltrate, connective tissue necrosis, and large dermal abscess. So if the deeper lesion proceeds like this, then it results in the formation of a cystic acne. So the ruptured comedones may undergo re-epithelialization. There's always a reparative process, or they produce a secondary comedone, or they're always distorted in shape. There's residual inflammation even after healing, and then with the process of healing being continuous or after a long term, we see scarring. Scarring in skin is seen as dense collagenization. So when we call this as a cyst, epidermal cyst is larger in size and absence of sebaceous acini and hair. Sometimes it may be difficult for us to differentiate the cystic stage of acne from an epidermal cyst. So abnormal flora and anaerobes, not just propioniform bacterium, so such as Corynebacterium acne, Pityrosporum ovale, Staphylococci, they all cause splitting of this. They split sebum into fatty acids and triglycerides, which are again irritating factors. So they act like chemical irritants at the site where there is a rupture and evoke inflammation. So this is again, I told you, neutrophils accumulate in the comedones, the rupture of the follicle and formation of a pustule when they rupture superficially. Now, can you identify this? Let it be a task for postgraduates. Hope you're not sleeping. The caption for this picture is there, but I want you to identify. What is this? Where are we? Are you getting the picture of the site? Now, I have not shown you the entire follicle here. It's only a part of the follicle. What is this? This is the secretion inside. Do you remember the secretions I showed you in the earlier pictures? Is it different from the previous pictures? Remember the glose comedone at least? It had secretions. Is it looking similar to that? No, that was just pink laminated keratin that we saw. So this has got a lot of bluish structures. What are they? Right or wrong, please tell me. Because dermatopathology, even it may be difficult for me unless I keep a book and then keep reading and seeing the slides.
Are the inflammatory lymphocytes? And what is that one? It's a giant cell, is it? There's one big one there.
This is just the secretion. So these are all inflammatory cells. So this is the keratin. Can you still make out the laminated keratin, the layers of keratin here? And this is the thin wall of the follicle, hair follicle. We don't have that extra. So this is just a part of it which is shown in high power. Next. This is clear? Can you identify this? This from the routine books, the book what we refer, Lever's Histopathology. What is this? I told you what the mind does not know, but all of us know. I have given you a basic outline of the normal thing also. What is this? Sir tells me what it is, but please, this is to wake you up if you are sleepy, to make you active. Is it not the epidermis? Yes? Why don't you say that? Can you make out this? What is the layer on the epidermis? Keratin. You can see this keratin. So what is this here? The pilosebaceous unit. Pilosebaceous unit. So is it open, closed? Open or closed? It is open. So what is it containing? Lot of inflammatory cells. So what can we call this as? It is not just sebum and keratin which has gone to the surface with an open infundibulum. This got inflammatory cells. We are in the inflammatory stage of acne. This is a pustule. This is a pustule. So what has happened here in the dermis? We don't see so much of disturbance in the dermis. This is especially this is the papillary and this is the reticular dermis we are seeing. So lot of inflammatory cells here also. That means there is some amount of rupture. The follicle has ruptured into the deep dermis and evoked inflammatory reaction. So this is a pustule here and an inflammatory reaction deeper down in the dermis. Next. This is very easy to recognize because this is what you keep seeing, the pustule. Next. So perifollicular pustule. So when the comedo when it ruptures, so it evokes inflammatory reaction. So we were talking about neutrophils within the follicles, but when it ruptures in the perifollicular area, we do see lymphocytes, plasma cells and foreign body giant cells. I told you why foreign body giant cells. It is the reaction against the keratin, the sebum which is liberated. So many of the foreign body giant cells, you may see the enucleate keratins are present in the giant cells too. The follicular epithelial cells encapsulate the inflammation and the draining sometimes draining sinuses will form which are lined by remnants of follicular epithelium. Next. What is this? Is it looking different from the closed comedo, open comedo, a pustule and a deeper reaction? Looking different in what way? It's got a broad mind now. It's so capacious, it's become so big. Means this is a cyst. It's become cystic. So much of dilatation of the follicle here. So with inflammatory cells, you can still see the keratin. So cyst-like follicular dilatation, and we are not seeing this communicating to the surface, but there's a lot of inflammation in the surrounding area. That means this has ruptured. There's no continuity here. It has ruptured, giving rise to the inflammatory reaction in the surrounding dermis.
Can you differentiate that from the sebaceous cyst?
Definitely, sir. Definitely.
Infected, definitely.
Yes. So sebaceous cyst has got a different lining. We don't see granular cells in a sebaceous lining. Whereas the hair follicle lining always has the granular layer. So sebaceous, we say abrupt keratinization. Next. So the next process is definitely a healing process which results in scars. It's nothing but dermal fibrosis. So there may be a fibrotic mass and anywhere in the scar area it will be devoid of the adenate cell structures. There may be perifollicular fibrosis. So mild cases you may still see the follicle and fibrosis around. Then elastocytolysis, and as we have already learned, any area dead and degenerating, the secondary change we see is deposition by calcium. So there will be dystrophic calcification and sometimes a metaplastic change. Very rarely, so there could be formation of bony tissue there. We call it as osteoma cutis, and of course hemocytosis. If there is a lot of hemorrhage where the RBCs for repair they are lysed and then the hemocytrin that is liberated. So dermal fibrosis is seen in later stages. So pustule forms when this is just to summarize what we have learned. Pustule forms where the follicle ruptures superficially. Nodule forms when the follicle ruptures in the deep dermis. Then gram-positive diphtheroids may be seen free or within the neutrophils in the inflammatory infiltrate, and extensive cellular infiltrate connective tissue necrosis and large dermal abscess form the cyst, and they are the ones which are seen in the cystic form of acne. Differential diagnosis, I've just put it. and I don't think you do a biopsy of acne, but yesterday we received one biopsy of acne. I was very happy to see that, but we could not process to make slides. I remember one postgraduate in JJM had taken an thesis on acne, Alyssa. So otherwise, though we talk so much about the pathology of acne, we hardly look at these lesions in our practice. Whereas the other lesions in skin, I think out of experience, we can talk more about it. So this I feel has formed a lot of bookish knowledge, because not much of acne biopsies is I've seen that are biopsied and seen personally. But one postgraduate, as Dr. Murugesh also says, had taken dissertation on acne. Because differential diagnosis, bacterial and fungal folliculitis, so we have other criteria. So fungal folliculitis, definitely we appreciate the fungi, though not microscope with HND, sometimes with special stain. And your clinical appearance of these lesions also contributes to us. And in a fungal lesion, we do see a lot of micro abscesses. And pilosebaceous unit may not show such a marked change, but there could be eosinophils and there could be more plasma cells as well as foreign body giant cells and micro abscesses, which give us a clue to the presence of fungi. And of course, special stains like pyridic acid shift, which is the most commonly widely used or done fungal stain, can be used for demonstrating. Then acne rosacea shows several features, but there's a lot of telangiectasia. I don't think these biopsies, we need to have a differential diagnosis microscopically, because I told you again, most of these diagnoses on histopathology are based on your clinical findings. So we always say correlate when a definitive diagnosis is not possible, correlate with the clinical features so that both put together we may conclude or come to a diagnosis. Just few minutes now. Most patients with acne are likely to have glands locally hyperresponsible to androgens. Other factors that can cause increased androgen production could contribute to this. So I told you about higher serum levels of these androgens. Then acne tends to resolve in the third decade as the androgen levels decline. And then next, some acnes are induced by drugs. Then acne may develop de novo in adulthood. And post-adolescent acne affect women. Then repeatedly, many of the authors say it is hyperandrogenous. Family history in HOF and premenstrual flares in older women and adolescent acne with a male predominance. Next. These pictures, I'm sure clinical colleagues are going to talk about it. Next. It's just a cystic. So when follicles rupture, I told you, they can give rise to any of these lesions. But they accumulate the exudate, forms a cyst. Next. Next. So a lot of external factors, oils, greases or dyes in hair, products, cosmetics, then repetitive trauma, humidity, perspiration, all are supposed to be the etiological factors. Next. So role of diet in acne is quite controversial, though one of these study is showing a relating intake of milk to acne. Next. Stress, ACTH, all these can cause acne. There are a lot of drugs which are there. I think with the clinical practice, a dermatologist can add to this list, and they may say how exactly this has a role in inducing acne. So genetic factors too. So more than one member of the family is affected, that increased incidence. Next. So hormones again. Sebaceous glands, we said how androgens act on the sebaceous gland. Next. So if you just go on looking at the causes, a lot of queries, a lot of question marks, whether they're implicated in implicated as an etiological factor for acne. But one of the author very clearly has put it as not due to chocolates or fatty foods. Because this is, as Dr. Chandramohan was telling, it's an adolescent problem. So at that age, everybody wants to look beautiful. We have the plastic surgeon here. So many of them go to him because skin is the index of beauty. Everybody wants to have that fair, clear, very nice complexion and a nice skin. But it is at this time, a lot of these acne appear as probably villain in their age group. And I go to a lot of schools for school health programs, and this is a problem, that almost all the girls face. And a lot of psychological trauma also. That's why I feel, more than talking about the pathogenesis, how best this could be treated, and though it's not a life-threatening disease, as already Dr. Chandramohan put it, but it gives a lot of psychological trauma to these adolescents. Okay, next. So this is for our clinical people, probably looking at the site of lesions. They have other differential diagnosis when they look at clinically the lesions. So this is just to show two pustules which are there. This is the steroid acne. They're tiny pustules confined to the hair follicle. You can make out the layer, but they're not just open to the surface. So there are a lot of types of acne. So what is important, I told you, is why is this important? So treatment. Anybody has this problem, they're not bothered about the pathogenesis, though as clinicians we need to know, because as is your pathology, so is your medicine, they say. So clinician could be the best clinician if he knows the pathological process. So I think I end at this stage. I feel I've given you a basic picture of how pilosebaceous unit is and what are the changes that occur in an acne, whether it is at the non-inflammatory and the inflammatory stage. Next. So these are very rare forms. Even definitely I'm not quite well versed with these other forms of acne which are there. Next. So hope you've all heard about what I said with lot of attention, because we say attention improves retention. And more than the questions here, I want you to contribute your knowledge. I have a lot of dermatology professors here, so who can add to this. Because I told you, hardly I've seen biopsies of acne. So though all other skin lesions, they are quite familiar with. And I can say I have a passion for dermatopathology. So I've made Dr. Jagannath Kumar and his colleagues now to submit whatever that is removed. So I've told his junior staff to send me even a wart that is removed. I said, please don't throw it, send me the wart. Each one has a different appearance. So they have started sending me all types of, whatever pottery they do, they remove the wart. And I've told them even to send molluscum contagiosum. And I was giving this task to Dr. Murugesh when I was there. He has given us one biopsy of scabies also. That my professor has with a mite inside. That's okay. Many may not agree, but academic purpose, we need to use that. And molluscum contagiosum has become a routine slide for our pathology undergraduates also. So anything that is removed, please do not throw them. Send it to histopathology. So what we think, what it looks macroscopically may be different microscopically. So I make my clinical colleagues of ENT to send even the tonsils they remove. It might have something inside. It's all a learning process. Thank you very much. I thank Dr. Jagannath Kumar for having given me this exercise to read about this and learn first and present it before you. Excellent learning opportunity for me to be with you. And you may just say I'm in a medical education. I just want to share one thing. So my teachers in medical education, especially Dr. Srinivas, who is called as Pitamaha of medical education, he always says, teachers to be not on the dais. He says the concept has changed. Teacher is no more a saint on the stage, he is a guide by the side. So whenever you want to teach, I feel the UGs, so not to use the dais, and if you are probably with the learners, because it's a learning process for us. Teacher is an ever learner. Thank you.
The topic is now open for discussion. Any questions from the audience?